Welcome to Compass Opioid Stewardship in Practice. Each week, our Compass coaches will explore a real-world case, define a clinical goal, and walk through practical strategies to improve care. Whether you're tuning in via video, audio, or reading the summary, this session is built for busy clinicians like you. Enjoy the show. My name is Dr. Don Stater. I'm an emergency and addiction medicine physician and the medical director of the Compass Opioid Stewardship Program. This week's case features Greg, a 42-year-old male patient who, while lifting a box at work, developed sudden lumbar back pain. The pain is non-radiating but debilitating. The patient was seen in the emergency department where he was diagnosed with a back strain and provided with prescriptions for cyclobenzaprine and lidocaine patches. In addition, the patient has been using over-the-counter NSAIDs and Acetaminophen with mild relief. He sees you in clinic concerned about his continued pain and asking what else can be done. On exam, the patient has areas that are exquisitely tender to palpation at his left SI joint and left perilumbar region around L4, L5. This is the perfect patient to consider an in-office trigger point injection. Trigger point injections are an effective and safe intervention and the subject of today's microlearning. First, let's start with some definitions. Trigger points are a type of myofascial pain. They are thought to be caused by localized injury, muscle spasm, and sensitization after injury. If you've ever had a tender knot in your back, you've known what a trigger point feels like. Trigger point injections are a procedure in which a clinician injects trigger points, typically with local anesthetic to relieve pain. Although studies have shown that dry needling or even injection of normal saline can result in similar pain relief. There is no actual local anesthetic that has been shown to be superior to any other. So you can really use any local anesthetic that you want if you're going to use a local anesthetic. Trigger point injections can be done all over the body, but are typically done in the posterior neck, upper, and lower back. The evidence of benefit is significant. One ED-based study showed that trigger point injections for back pain resulted in faster and more significant pain relief than IV NSAIDs like Toradol. Patients often experience significant relief in less than 15 minutes. Other studies have shown significant benefits in terms of pain control and return to function. As a clinician, I enjoy doing trigger point injections and find them to be of significant benefit to my patients. So let's talk clinically about how to identify trigger points and perform trigger point injections. First, the diagnosis is made by palpation and a focused physical exam. You palpate for either taut bands or hypersensitive nodules within skeletal muscles. These are how you identify trigger points. At times, patients may exhibit what's called a jump sign, where they flinch or jump away from your palpation, or have referred pain patterns when you push on a certain area or trigger point. Bottom line, any area with significant tenderness palpation is a potential target for trigger point injections. Once identified, consent the patient by discussing the procedure and potential risks, which include bleeding, infection, and unintentional injury to adjacent structures. The lower lumbar area in particular is very safe for injections and has really no other adjacent structures at risk of injury. Obtain verbal or written consent based on your clinical setting policies. When I do trigger point injections, I typically use a 10 cc syringe and a 27 gauge needle. And I like to inject between 10 and 20 mLs of local anesthetic in my trigger points. Afterwards, I often conduct dry needling, where I needle the muscle to break up tense muscle fibers. You can find a video of how I like to perform trigger point injections in the show notes. So back to the case. Greg agrees to lumbar trigger point injections. You inject a total of 4 trigger points with a total of 4 mLs of 0.5% bupivacaine each. The patient feels significant relief and no new medications are needed or prescribed. You give the patient reassurance that his back pain should improve in the next several weeks. You refer the patient to physical therapy, and he's back to his normal self when you see him in the next month. So let's summarize some of the clinical pearls. 1, trigger point injections are effective for localized myofascial pain and can be done in the outpatient office setting. 2, you can use any local anesthetic or even normal saline in trigger point injections. 3, trigger point injections combine very well with other multimodal therapies, including physical therapy or non-opioid therapies. 4. Trigger point injections are a billable procedure, which clinicians can document and for which clinicians can receive compensation. And 5, if you have any questions about trigger points or anything else regarding opioid stewardship, please reach out to one of your Compass coaches. Thank you for tuning in. This show has been brought to you through the generous support of the Centers of Medicare and Medicaid Services. Thanks for joining this week's Compass Opioid Stewardship in Practice. Thank you for being part of the Compass Opioid Stewardship Program, and thank you for all you do caring for your patients. See you next time.